Welcome to Cardiac Imaging Aura. Today we will have a new session dedicated to the innervation of the heart. So you know that sympathetic nervous system activation plays a very important role in supporting cardiac function in both health and disease conditions. And this mechanism is operated by the release of norepinephrine, that is the physiological neurotransmitters, binding alpha and beta adrenal receptors and undergoing reuptake by presynaptic, this is the uptake number 1, and extraneuronal transporters, the uptake number 2. While this mechanism ensure an optimal norepinephrine turnover in a normal neuronal stimulation, they cannot compensate the overflow or norepinephrine during high and prolonged stimulation frequencies, as we can find in patients with, for example, congestive heart failure, in which the postsynaptic receptor downregulation and the enhanced norepinephrine spillover by the presynaptic reuptake mechanism leads to diffuse functional denervation of the heart. If we speak as normal cardiologists, clinical cardiologists, we know that we can detect the norepinephrine spillover, for example, with the plasma assay, or why not with microneurography, or with an Holter EKG evaluating the heart rate variability, or at the end with the barochemoreflex stimulation. In all these cases, we have an indirect evaluation of the status of the neuronal innervation of the heart, normal, abnormal. All these things are indirect evaluation. With nuclear imaging, we have the possibility to evaluate in a semi-quantitative and quantitative way, in a visual way, which is the real state of the heart of the innervation. And we can evaluate the functional integrity of cardiac sympathetic terminals, mainly through the use of radiotracers that are analogs of norepinephrine. We can use PET and SPECT. In this session, we will speak about the use of tracer dedicated to SPECT, that is more simple to use, more cheaper, rather than those evaluating the integrity of the neuronal systems with PET, even if, to be honest, PET evaluation is a little bit better in terms of quantification. But for clinical purpose, we can use this tracer, that is a very old tracer, is an 123 iodine MIBG, that is allow an evaluation of the integrity of the presynaptic receptors, and is a non-metabolized norepinephrine analog that undergo the reuptake by the uptake 1 mechanism, and it represents the reference for the non-invasive evaluation of cardiac adrenergic nervous function. So in the last decades, there are lots of publication about these tracers that allow the demonstration that the presence of cardiac sympathetic dysfunction is present in different cardiac pathologies, and there is a strict correlation between the adrenergic nervous system impairment to the adverse patient's prognosis. So we can obtain two different kind of evaluation: the planar evaluation, that is the oldest one, and the SPECT evaluation, that is the new one, and is probably a little bit better in terms of visual analysis of the uptake of and the integrity of the adrenergic nervous system. But How we can do it? It's very simple to use. We injected the MIBG at rest. The amount of tracer is not well stabilized, wasn't very well determined, because in the past we injected a lot of tracer for in a planar evaluation with the oldest camera. It's about 10 millicurie. Now with the new camera, we can inject lower than 2 millicurie for obtaining a very high quality images at the end. But so, for example, you can inject from 3 to 5 millicurie for standard SPECT, and after 50 minutes, you need to acquire the planar scan, and then you need to apply the SPECT scan. And they represented the early image detection. And then after 4 hours, you need to acquire planar and SPECT again in order to obtain the delayed images. For planar evaluation, as evaluated here in this picture, you need to have a region, you need to draw a region of interest around the heart and in the mediastinum in order to detect the number of counts that you have here and here, for obtaining at the end the heart to mediastinum ratio, that is a number. The normal value is higher than 1.6. If in this case you have a normal integrity of the adrenergic nervous systems, while if you have a number lower than 1.6, you have a decrease of the integrity of the system. It's very important to detect also the washout rate, that represents another variable to obtain the evaluation of the status of the heart of the system. And you can use this kind of formula for the evaluation of washout rate. But when you need to use MIBG, you can use for several purposes. Probably the most important one is dedicated to heart failure. You have a lot of published paper around it. The most important one is the ADMIRE paper. And this is the representation of the results obtained by the ADMIRE session, the ADMIRE study. You have 961 patients with NIA class 2 or 3 and an ejection fraction lower than 35%. And here we have an example of the 3 kind of patient that you can have described in this study. This is the first one. Apparently, there is no MIBG detection, no heart. This is the second one. In this case, you can obtain probably here a little bit of uptake of MIBG. And here you have the third one. Here you have the heart. So in this case, you have 3 kind of patient that apparently from for a center point of view, a clinical point of view, they are quite similar because their ejection fraction is between 20 and 25%. In this case, the first case is the value of BMP is very high, higher than 1,000. In the other 2 cases, the BMP is lower than 100. But so in this case, the heart to mediastinum ratio is 0.96, so very low. And this patient died at 8 months after the MIBG evaluation for heart failure progression. In this case, the heart to mediastinum ratio is 1.38, so higher than this one, the previous one, but lower than 1.6, that is the cutoff value. And also in this case, this patient died for sudden cardiac death. In this patient, the clinician decided to not use the high CD. And in this case, we have a heart to mediastinum ratio higher than 1.6 because it's 1.67. And at 8 months, this patient had no events. So 3 different kind of patient, and you can increase the evaluation of the risk using MIBG apparently. I would like to show you one cases from our hospital. This is a man of 61 years old. He has a progressive reduction of exercise tolerance without angina in NIA class 3. He has family history for coronary artery disease, hypertension, and diabetes mellitus. From his anamnestic data in 2010, he has an inferior myocardial infarction treated by revascularization with PCI and stent on RCA, and he was treated with aspirin, ACE inhibitors, and beta blockers. He arrived at our attention for an evaluation of echo, and we detected a reduction of ejection fraction from 47 to 36. So he was submitted to CT coronary angiography for the evaluation of coronary anatomy, and there is an occlusion of the RCA, while LAD and LCX showed no significant stenosis at coronary angiography. At EKG, there is a LBBB. So we decided to submit the patient to MIBG, and you see that we found a heart to mediastinal ratio of 1.56 in the early images and 1.51 at delayed images, with a washout rate of 15%. So it's very low washout. And you can find here that there's a big amount of uptake in the anterior wall, while there is no uptake in the inferior wall. And it's quite the same here. There is also a big uptake of MIBG in the lungs, but we can talk about the uptake of MIBG in the lung in another session of cardiac imaging Agora. But if we analyze the regional uptake of MIBG compared to the perfusion evaluation obtained by SESTA-MIBI at rest, in order to detect the match and mismatch between MIBG uptake and perfusion uptake in the same day, in the same condition, we can find here we have the bullseye obtained with SESTA-MIBI, and here we have the bullseye obtained by MIBG. You can find that there is a mismatch in the LAD territory, while here, for example, we have relatively reduction of uptake of MIBG in the septal wall. Here there is an uptake, normal uptake, and also here on the LCX and in the apex. So if you analyze here in the different slices the uptake, you can find here a reduction of perfusion, but is still present perfusion in the apex, while there is no uptake of the MIBG in the same territory. And also here there is a reduction in the you can find here in the lateral wall, and so also in the septum. So there is a mismatch between perfusion and function. Here it is a function obtained by, so you see here, there is a reduction of the function obtained at gated images during the evaluation of perfusion. Moreover, you can find here there is a big difference in terms of dyssynchrony. So this is a dyssynchrony in this intraventricular dyssynchrony in this heart. Is a big amount, is quite extension of this synchrony. So at the end, we can conclude that there is a volume overload with this synchrony rather than ischemia that probably are responsible for heart failure symptoms. And there is also a mismatch between perfusion and innervation with a lower reduction of MIBG. So we decided to treat this patient with CRT and defibrillators, and after 2 years the patient is quite good. There is a reduction of symptoms and improvement of ejection fraction from 37 to 41, but the patient referred an improvement of the quality of life. But there is another role for MIBG that is quite correlated to the previous one, but is probably another way to use it. And probably in the future, if this data will be used and reproduced by other center in more patients, it could be a very good use for this tracer. So I would like to start with a case. This is a case of a female of 62 years old with acute chest pain, hypertension, hypercholesterolemia, and you see that she's arrived at our attention for acute myocardial infarction in the anterior wall. And she was treated with revascularization within 2 hours from the onset of symptoms. So apparently, the case is resolved and everything is good, but are we sure that everything is enough? What could we do in this patient? So if we analyze this data, this is a very nice study because it was published several years ago, but we have a planar evaluation of myocardial viability with thallium-2-1 and evaluation of innervation with MIBG. These are planar images. Here you have the septal wall, apex, anterior wall, lateral wall, and the same with MIBG. They studied 12 patients with acute myocardial infarction, and in all patients where mismatch were present between viability and MIBG, in all these patients you have ventricular arrhythmias. So it's very interesting, but if you think that MIBG evaluated the integrity of presynaptic vesicles, you can find and you can arrive to understand in a very simple way that if you have the absence of MIBG uptake, it's the demonstration that there is no possibility to the reuptake of the norepinephrine. So you have a lots of norepinephrine that is free in the presynaptic wall. So what does it mean? It does mean that in presence of a viable tissue, you have a lots of norepinephrine, so you have a lots of arrhythmogenic stimulus, so you have the possibility to have arrhythmias. So in this condition, the mismatch between innervation and viability, it's the demonstration that the risk of arrhythmias is increased. And we have a lots of demonstration that in presence of ischemic damage, the neural damage is larger than ischemic area, and in this case, the sympathetic denervation in a viable area, it's related to a supersensitivity that may be arrhythmogenic, and in presence of viable myocardium, you can have arrhythmias. So here there is another study that demonstrates in a very simple way the sentence that we previously analyzed, and also here there is another very nice study that demonstrates the close correlation with presence of denervation, viability, and the electrophysiological correlation between this kind of variables in patients with acute myocardial infarction that were revascularized earlier. So if we come back to our patient, we see that we have this revascularization within 2 hours from the onset of symptoms. So what could we do? We decided to submit this patient to an evaluation of viability and innervation, and it's very nice because in the first row you have the evaluation of viability, and you see that there is viability in the wall myocardium. You have a revascularization within 2 hours from the onset of symptoms, but if you analyze the innervation here, if you compare these two slices, and here these slices, perfusion viability and innervation, you can have the in a very simple way the demonstration that there is a damage of the innervation, there is a reduction of the MIBG uptake in the anterior wall that is correlated to the site of occlusion of the LAD. So you have a big area of mismatch. This is the bullseye of viability and innervation, a big area of the mismatch in the LAD territory. What does it mean? It does mean that you need to put your attention on this kind of patient. You need to be sure that there is no extracerebral, because as in this patient, after 3 days, she has this kind of event. So we need to treat them with a high amount of medical treatment, antiarrhythmics, medical treatments, and with an evaluation in the next month with Holter EKG in order to obtain more information about this kind of situation, in order to detect if this patient needs, for example, different kind of treatments. So the use of MIBG could be of help in dedicated subset of patients in order to detect if the correlation with arrhythmias, if medical treatment should be a little bit different, or if you need to think to other things, could be used. So the interpretation of adrenergic systemic nervous systems images with MIBG requires the knowledge of different topics: neuronal biology, tracer kinetics, specific disease state, the possibility to help in understanding the pathophysiology of the different disease could add new dimension to this kind of imaging. There is a lot of limitation in tracer viabilities, in quantification of methods that up to now miscourage the clinical utility of this tracer. However, the use of the new cameras for MIBG, and why not the use of new tracer for PET, but we will discuss about PET in a specific session, would take advantage of the improved spatial resolution, quantification, and potential wide distribution. Before innervation imaging can become a part of clinical practice, larger prospective and randomized control trials are required to confirm if these images can guide clinical management, that can impact on outcomes and its cost effectiveness to do so. So thank you very much for your attention, and I hope that this session could be of help for you for clinical practice. Thank you very much.